friends, we are starting up with gynae, and then we will be discussing the obstetrics. So, I'm Dr. Harmeet Goel, your Obs and Gynae faculty, and taking, the test and discussion for Obs and Gynae for the upcoming exam of your FMG. Okay. So, presently I'm working in Rajiv Gandhi, that I have already explained. This is a private hospital. Rajiv Gandhi Cancer Institute and Research Center, Rohini. It's, that is its branch. Niti Bagh, its branch. This is main in Rohini, 500 bedded. In the ranking, it's number 1 in Delhi Cancer Institute, and all over India, it's number 2. Now, what I'm going to cover, what is my focus? My focus is like clinical pattern questions, previous year's questions, rapid fire, revising obstetrics and gynecology in 2 parts, single liners, images and image based questions. Okay. So let us just start up with the gynecology part. So I am discussing gynecology questions first, and then I will be discussing the obstetrics. So let us take up the question. So question number 1, wife of vasectomized husband comes with 3 months amenorrhea. What is the likely cause? Surgical failure, spontaneous recanalization, failure to use backup method for 3 months of vasectomy, wife having an extramarital affair. So most appropriate answer you have to mark. So whenever we do a male sterilization, which is vasectomy, we always tell the couple to use backup method of contraception for 3 months. Now, why this backup method is needed? Because after the vasectomy, sperms can stay in the tract and failure can occur. So, the correct answer is failure to use backup method for 3 months after vasectomy. Now, tell me, what is the failure rate of vasectomy? It is 0.15 per 100 women year. Now, how do you express the failure rate of any contraceptive method? It is by the formula of Pearl index. Pearl index is to calculate contraceptive failure, and it is always expressed as per 100 women year. Always expressed as per 100 women year. So, vasectomy is being done by non-scalpel technique or no stitch vasectomy. No stitch vasectomy. Now, is there any chance for recanalization after vasectomy? This is the most commonly asked question. Yes, there is always a chance for recanalization whenever the need arises, but it has to be very, very genuine indication. Fine. So, failure rate of various contraceptives, you should know. If it is oral contraceptive pills, what is the failure rate? 0.1 per 100 women year. 0.1 per 100 women year. Failure rate of copper T 380A is 0.6 per 100 women year. Failure rate of Mirena, 0.1 per 100 women year. Failure rate of laparoscopic sterilization is 0.6%. Failure rate of tubectomy by Pomeroy's technique. Some of the questions have already asked in your previous FMG exam. So this is 0.1 to 0.4%. Failure rate of Nuva vaginal ring. is 0.3 per 100 women year. Failure rate of DMPA injection, that is, what is the name? It is, like freely available in the government sector. It is Antra. It is 0.3 per 100 women year. Failure rate of Implanon. Implanon is subdermal implant. Implanon is subdermal implant. So, the failure rate of Implanon, which is subdermal implant, is 0.05 per 100 women year. So, these are some of the failure rates of important contraceptive methods. Failure rate of some of the important contraceptive methods. Fine. And this question has already been asked in FMG exam. So keeping in mind what is the present type of questions being asked, accordingly I have prepared this test and discussion for you. Now let us take up another question. This is again an important question. Like, all of the following regarding non-scalpel vasectomy are correct. Non-scalpel vasectomy is NSVT. All of the following are correct except students know the answer, but they tend to make mistakes whenever a question is being asked in the form of except. Okay, so let us read the options so you can assess your marks accordingly. Okay, so here in the class itself, this is just a revision session for you. So, sexual function following healing is rarely affected. Hematoma in up to 5% of subjects may occur. Sterility immediately after vasectomy and recanalization is possible. Which of the following is a wrong statement according to you? Excellent. Your answer is absolutely correct. I just mentioned in the previous question that like backup method is needed for 3 months. A backup method is needed for 3 months or for 90 days after vasectomy. So it's very clear that immediate sterility is not seen because some of the sperms can stay in the vas deferens and failure can occur. It's always better if after 3 months of vasectomy, that during the 3 months couple has used the additional method of contraception. Most of the time it is condoms, and the person should come for a semen analysis and there are no sperms in the semen. Then further no backup method will be needed in that situation. Next question. 35-year-old female undergone suction evacuation. She is not able to give exact history but told some blood investigations were done at weekly intervals. Suction evacuation. Friends, my concept was to create a clinical pattern of questions. Some of the questions I have created myself just to give you a fair idea what type of questions are expected in your exam. So suction evacuation was done and the lady is not able to give us the exact history, but at weekly intervals some blood investigations are done, and now she comes in the gynae OPD with continuous bleeding for last 1 month. All of the following investigations are relevant investigations except. So what will you mark? Beta HCG, ultrasound, chest x-ray or hysteroscopy, which is your wrong answer. Hysteroscopy has got no role. What is this suction evacuation? Suction evacuation might be done. For what? Because weekly intervals, what investigation you are going to order? It is suction evacuation done for H-molar pregnancy. After H-mole evacuation, that you do weekly beta HCG levels, and after it is negative for 3 weeks, you do it at monthly intervals. Okay, so what you are suspecting in this case, after an H-mole evacuation, around 15% there is chance for non-metastatic GTN, and 4% chance there is a chance for metastatic GTN. In the first case, it may be residual mole, and in second case, it is choriocarcinoma. So, keeping this in mind, what all investigations are important? Suction evacuation has already been done. So, I am going to do beta HCG, serial beta HCG. That is rising titers of beta HCG, rising titers of beta HCG, even ultrasound is important, even chest x-ray is important, because if you suspect choriocarcinoma, then the most common site of metastasis is lungs. Students, you are all well-read students, you are all intelligent, but I am creating a concept how to come out with the correct answers. See, hysteroscopy has got no role. You have never read that hysteroscopy is the investigation done for gestational trophoblastic tumors? No. For an H-molar pregnancy, ultrasound shows snowstorm appearance. But for choriocarcinoma, it is always the rising titers of beta HCG. Why chest X-ray is important? Because lung metastasis is the most common site of metastasis. See, when I am discussing a question, I am just not discussing a question and answer. I am discussing 5 relevant points and MCQs along with that. So my way of discussion is little bit different. I don't just take up question and answer. Okay. So what did I told you? H-molar pregnancy. What is the ultrasound finding in H-molar pregnancy? Friends, it is snowstorm appearance. Number 2. What is the management of H-molar pregnancy? Suction evacuation. Number 3. What is the most common recurrence after an H-mole evacuation? Is residual mole. And students, this question has been asked in FMGE exam. Most common trophoblastic tumor developing after an H-mole evacuation is residual mole. It's not choriocarcinoma. Okay, it is residual mole. Invasive mole is another term for a residual mole only. Okay. Now, what is the treatment for choriocarcinoma? Is chemotherapy, and the main drug is methotrexate. Fine. So, site of metastasis lungs, treatment chemotherapy, methotrexate is the main drug. H-molar pregnancy, ultrasound is the investigation of choice, and what is the feature? That is snowstorm appearance. Done. Next. And what is the investigation you do in follow-up? Is beta HCG. Now, one more. A patient of choriocarcinoma needs to be on follow-up for at least 1 year or 2 years, depending upon low risk and high risk. Tell me, the choice of contraception this lady must use. She should not get pregnant during follow-up. Why? Because in pregnancy, there is beta HCG, and recurrence of trophoblastic tumor is beta HCG. How will you differentiate? So, any patient who is having cancer and she is in the follow-up, she should not conceive. Okay. Now, what is the contraception of choice? OCPs? No. Correct answer is OCPs. It's always OCP is the contraceptive of choice. Oral contraceptive pills is the contraceptive method of choice because failure rate is just 0.1. Okay. Next question. Female has undergone DNC. This is again FMG exam question. So those students who think ki some question or the other is difficult, it is not difficult. It is your exam pattern which I am discussing it here. I am taking the classes in PG as well. So PG pattern is little bit different, not very different, little bit different from yours. So female has undergone a DNC for missed abortion. After that, she has developed secondary amenorrhea. FSH levels is 7. What is the likely cause in this case? TB, Asherman syndrome, PCOD, Sheehan syndrome. Excellent. So you have prepared Obs Gynae very well. That means good. See, whenever there is a DNC followed by secondary amenorrhea and FSH levels is given normal. Normal FSH is 5 to 20 international units per ml. Always your answer goes for Asherman syndrome. What is Asherman syndrome? Asherman syndrome is formation of synechia between anterior and posterior uterine wall due to vigorous curettage performed at DNC. So they are writing in the question, a DNC was done for a missed abortion and she has developed secondary amenorrhea after that. Because when you have done curettage, you have destroyed the endometrium till the basalis layer. So she will develop oligomenorrhea, secondary amenorrhea and infertility. So she has come to you with secondary amenorrhea after a DNC being done. Plus, they have given you FSH so that you do not think of Sheehan syndrome. Okay? And it does not fit into TB. Why you are going to do a DNC in a case of tuberculosis? No sense. And in PCOD, DNC is never indicated just for the sake of secondary amenorrhea or menstrual disturbance. You give progesterone or you give OCPs for the treatment of PCOD. You give ovulation induction if it is a case of infertility. So none of the three options fit into this. DNC leading to amenorrhea, FSH normal is Asherman syndrome. Next question. This is an FMG question. Another FMG exam question that you have to tell me the gold standard investigation in Asherman syndrome. It is, friends, hysteroscopy. Because Asherman syndrome is occurring in the uterus. Asherman syndrome is adhesions occurring in the uterus. So how do you check for the adhesions, friends? You are going to check the adhesions by hysteroscopy because you are going to treat the adhesions by hysteroscopy. So treatment for Asherman syndrome or gold standard for Asherman syndrome is hysteroscopy and hysteroscopic guided adhesiolysis. Hysteroscopic guided adhesiolysis. Okay. So gold standard is hysteroscopy, that you will confirm your diagnosis, and when you're doing hysteroscopy, you're simultaneously breaking the adhesions. That is called as hysteroscopic guided adhesiolysis. Okay. This is what is the image of Asherman syndrome. This is HSG image. Okay. And this is hysteroscopy image. What you see here, these are adhesions. What you see here is adhesions. So hysteroscopic guided adhesiolysis is the treatment of choice. Fine. Anybody has any doubt in the questions, you can ask. Now, let me show the image first. Now, see, whatever you have attempted the paper, is it that you are giving your exam this time? No, it's a practice session. So maybe, like if there is any technical mistake, I have given the PPT like this. If there is any technical mistake, just forget it. You have to make your answer correct. Now tell me, which of the following is coinciding with the ovulation? That is what is the question. Which of the following is the peak responsible for ovulation? A, B, C or D? A. Okay. So the answer to this question is A. Now LH peak occurs 10 to 12 hours before ovulation. And which is the hormone responsible for LH surge? Is estradiol peak. Estradiol peak. And friends, those who think this is not my exam question is really wrong. Okay, this is FMG exam question 2020. Okay, so they have asked an image based question and I have already taken a recall session for the YouTube. So I know this question. Okay, so they have given the 4 peaks in this diagram which we have discussed in disorders of menstruation. That was my first slide. So I have explained that pituitary secretes gonadotropins, FSH and LH, FSH acting on the ovaries leading to maturation of Graafian follicles, and one follicle reaches a maximum size that is called as dominant follicle, 18 to 20 mm on transvaginal scan. Another question being asked in the exam. Then the dominant follicle secretes estrogen that is causing the proliferative changes in the endometrium, and this estradiol stimulates the LH surge. So which is the peak responsible for ovulation is LH. Okay, and estradiol is needed for LH surge. Fine. And you know estrogen inhibits the FSH and progesterone inhibits the LH. Hormone responsible for ovulation is always luteinizing hormone. This we have been reading through the PMT times when we were preparing and giving the pre-medical test exams. So this was in the school times. So you know it very well. Okay. Now, one more question which is important. Just to confirm ovulation, serum progesterone is one of the tests being done. My question is, it confirms that ovulation has taken place. So you have to tell me which day you will send the blood sample for. It is day 21. Day 21, corpus luteum function maximum is day 22, but serum progesterone sample is sent on day 21. Next, this is again your FMG exam question 2020, and they are very fond of asking such questions. So nobody should think that it is a tougher paper, it is a lengthy paper. This is just your revising the content. This is the best way you can revise, and just before your exam, do revise this discussion pattern in this same pattern which I am discussing. Definitely some of the questions will be coming in your exam. Okay, related. Maybe not the same language, but related questions. So hormonal profile in a menopausal lady has been a favorite question for FMG, and they have asked at least 4 times in FMG exam. So this is very important. Should not make a mistake in such simple straightforward questions. What's your answer? Increase FSH LH, decrease FSH, decrease LH. So the correct answer is FSH and LH is increased. Okay. Now tell me what is the mean age for menopause. Mean age for menopause, if I ask you worldwide, answer is 51 years. Again, that is a question of your exam. Number 2, in India, mean age for menopause is 47. So unless until friends, you are specifically asked about India, do not mention 47, 45, 49. Mean age for menopause is 51. This is a standard cancer textbook of gynecology NOVAX. Clearly mentioned that 51 years is the mean age for menopause. This is you have to remember. Now, in the menopause, it is 12 months of amenorrhea is called as menopause. it is 12 months of amenorrhea is called as menopause. Fine. Then in the menopause, ovarian function reduces. So estrogen, progesterone from the ovaries are down and there is no negative feedback inhibition at the level of pituitary. Pituitary secretes high FSH, high LH. Okay. So FSH more than 40 international units and serum estradiol less than 25 picograms per ml. This is the investigation for menopause. Of course, LH also rises. Okay, there is no ovulation. If these features occur in less than 40, what do you call it as? Yes, if these features occur in less than 40 years, we call it as premature ovarian failure. Premature ovarian failure, or the correct term is primary ovarian insufficiency. Primary ovarian insufficiency. Premature ovarian failure or primary ovarian insufficiency. If the same features occurring in less than 40 years. Now, two lines I would like to mention here. A patient has come to you at 25 years of age and her FSH, LH is elevated, serum estradiol is down. This is premature ovarian failure, okay, because it is at 25. Now she has developed secondary amenorrhea. What is the treatment for secondary amenorrhea? The straightforward answer is estrogen followed by progesterone in a cyclical manner. Why do you call it as cyclical manner? Because you give it and stop. When you stop it, there will be withdrawal bleeding. When you have given estrogen, there will be proliferation of endometrium. जब आपने progesterone दिया, there will be secretory changes. When you stop, there is shedding of the endometrium. So every cycle you have to give. Now, this same female, friends, comes up with infertility. The same female comes with infertility. Then what will you give the treatment? See, ovaries are not functioning. There is no ovulation and estrogen progesterone is down. So she wants treatment for infertility. So what will you give? Single line answer, it is IVF using donor oocytes. Means you give her estrogen and progesterone that will prepare the endometrial lining. You have given her estrogen progesterone to prepare the endometrial lining. उसके बाद you get a transvaginal scan done to check endometrial thickness is appropriate for implantation. Yes, it is appropriate. Now, you take an oocyte from a donor female, fertilize with the husband's sperm and do IVF. And once the endometrium is ready, do embryo transfer. Pregnancy support किससे देंगे? Progesterone. So, single line में IVF using donor oocytes for infertility and to treat secondary amenorrhea, estrogen followed by progesterone. What is the mean age for menopause? 51 worldwide. In India, 47. What is the single investigation to confirm it is menopause? Single, एक investigation बताओ. FSH. AMH is for infertility. I am not asking infertility. I am asking premature ovarian failure या फिर menopause में एक हार्मोन बताओ. तो आंसर सबसे पहला FSH आएगा. You don't write estradiol, you don't write LH, you don't write progesterone. Single answer, it is FSH. Okay. If they have asked the profile, then FSH, LH. If that is not given, then FSH and estradiol. ठीक है? क्योंकि FSH estradiol भी फिट हो रहा है, FSH LH भी फिट हो रहा है. It depends upon the options. दोनों ऑप्शन नहीं मिलेगा. Clear? Infertility treatment, IVF using donor oocytes, secondary amenorrhea treatment, estrogen, progesterone. ये इसी पैटर्न से you have to revise finally. Next. Which of the following ovarian function is normal? Let me tell you, this is not your exam question. It's a AIMS PG exam question, but you can judge the answer. Ovarian function is normal. सबसे पहले let us write the karyotype and the gonads. Testis is a male gonad. Karyotype is 46XY and ovary is a female gonad and karyotype is 46XX. चलो Turner syndrome karyotype जल्दी 45XO and what is the gonad? Streak ovary. Streak ovary. Is it functioning? It is non-functioning. तो आपको क्लियर हो गया. Karyotype, streak ovary, non-functioning and primary amenorrhea, most common cause. है ना? Periods will never come because ovaries are not functioning. Uterus is hypoplastic. Breast development 0. Next, Swyer syndrome. 46XY, streak testis. Streak testis. And it is again non-functioning testis and primary amenorrhea because it is a female looking person. Okay. Androgen insensitivity syndrome 46XY and there is undescended testis. It is functioning but defect at receptor level. So again primary amenorrhea. Again this is a female looking patient with a breast development normal. MRKH syndrome is 46XX and it is ovaries present but uterus absent and ovaries are functioning. That is why ovaries are functioning. So breast development is normal, axillary hair, pubic hair is normal. But why there is primary amenorrhea? Because uterus is absent. This is a type of Mullerian agenesis. I am really happy that you are really prepared the subject well. Okay? So MRKH syndrome and you are able to solve even the AIMS PG question as well with your concept. Always in your mind think of the gonad and the karyotype and the feature. खाली गोनाड एंड कैरियोटाइप नहीं करना है, आपको ये भी देखना है फंक्शनिंग है गोनाड की नहीं है. ठीक है, तो फंक्शनिंग तो सिर्फ मुलेरियन एजेनेसिस में है. दैट इज व्हाई ओवरी से हार्मोन्स आर रिलीज्ड, ईस्ट्रोजन, एंड इट इज कॉजिंग ब्रेस्ट डेवलपमेंट. एंड्रोजन्स आर नॉर्मल, कॉजिंग एक्सिलरी प्यूबिक हेयर डेवलपमेंट. सो आंसर टू दिस क्वेश्चन इज MRKH. व्हाई द आंसर इज नॉट टर्नर? बिकॉज टर्नर में तो स्ट्रीक ओवरी है, फाइब्रोटिक ओवरी जो कि फंक्शन ही नहीं कर रही है, तभी तो प्राइमरी एमेनोरिया है. कोई ईस्ट्रोजन नहीं है, शॉर्ट स्टेचर है, ऑस्टियोपोरोसिस का रिस्क इंक्रीज है बिकॉज नॉन फंक्शनिंग ओवरी. व्हाई नॉट स्वीयर सिंड्रोम एंड एंड्रोजन इंसेंसिटिविटी? उसमें ओवरी है कहां? इट इज टेस्टिस एंड कैरियोटाइप इज मेल XY. गॉट इट? क्लियर? नाउ टेल मी, type of congenital heart disease in Turner syndrome is bicuspid aortic valve or coarctation of aorta. Okay, then another question they have asked, type of congenital heart disease in Down syndrome. Very excellent. It is endocardial cushion defect. What is a type of congenital heart disease in diabetics? Baby of diabetic mother. Yes, excellent. Most common is VSD, but very specific is transposition of great vessels. Type of congenital heart disease in cases of rubella. Yes, patent ductus arteriosus. Most common congenital heart disease in pediatrics. VSD. And in adults, ASD. This is for your reference that if you are able to revise and remember this particular part. Okay. Type of congenital heart disease in Turner being asked in FMG exam, and they have not given bicuspid aortic valve as the option. They have given coarctation of aorta. Number 2, type of congenital heart disease in Downs is the recently asked question in FMG exam. So it is endocardial cushion defects. Type of congenital heart disease in baby of diabetic mother. VSD, if specific, it is transposition of great vessels. And the 2 I have already told you. Rubella, it is PDA. In pediatrics, it is VSD. In adults, it is ASD. They have not yet asked in your exam, but it is important. Fine. Now, next question. 14-year-old girl has well-developed secondary sexual characters, but amenorrhea. What should be done? Options: give ADH, antidiuretic hormone. Number 2, give GnRH, that will stimulate the axis. Okay, GnRH, growth, the gonadotropin releasing hormone released by hypothalamus, it will stimulate the pituitary and that will stimulate the ovary and she will develop periods. Estrogen, she will develop periods. No need to give any treatment. Smart children. See, again this is FMG exam, August 2020, which was the most difficult exam of FMG. So, why this answer is, so they have asked concept. Do you understand why I am discussing with the concept, not the single liners? I am adding up single liners very, very smartly. And I am adding up the PG questions very smartly along with FMG and new created questions. So it is full of masala for you. Okay. But you have to digest this because this is the way the questions will be asked. And this is your exam question. You can't challenge me. Okay. Chalo. Why no need to give the treatment? Because primary amenorrhea means in a 13-year-old girl, thilarchy, pubarchy, menarche all absent. Number 2, in a 15-year-old girl, thilarchy, pubarchy present, but no menarche. But your patient is 14 years. She is in between. If she has developed the breast, secondary sexual characters, what does it mean? It means breast development has occurred and it means axillary hair and pubic hair has occurred. Now, why you don't want to give her a benefit of 1 year? When thilarchy has occurred, pubarchy has occurred, menarche will also come. Okay, she has developed thilarchy, she has developed pubarchy and menarche she will develop. Maybe she will take 1 year to develop. Okay. So these two are developed, menarche has not yet developed, which she can develop in next 1 year. So no need to give any treatment. If you write any treatment, your answer will be wrong. I hope it's clear. Now, tell me fast, which is the hormone responsible for thilarchy? Estrogen. Tell me first visible sign of puberty in the girls. Visible sign is thilarchy. First sign of puberty in girls is growth spurt. First sign of puberty in boys, increase in the testicular size. I hope these questions are clear to you. Okay. So, increase in testicular size for boys as the first sign of puberty. Then, first sign of puberty in girls is growth spurt, but visible sign is thilarchy. Hormone responsible for thilarchy is estrogen. Now, hormone responsible for axillary hair and pubic hair. Very correct. It is androgen. That is why in cases of androgen insensitivity syndrome, axillary pubic hair are absent because androgens are present, but there is a defect at receptor level. So I hope these questions are clear. If anybody has any doubt, you can raise your hand, ask your questions. Now next question. 16-year-old girl having cyclical pain abdomen every month. She has primary amenorrhea, secondary sexual characters are normal, and there's a bluish membrane bulging. What's your diagnosis? Yes, I asked you first question as the diagnosis. So it is imperforate hymen. There was an image-based question in 2020 FMG exam. There was image-based question. Now, another name for imperforate hymen, what will you write? Hematocolpos. If that's not given, what's your answer? Congenital cryptomenorrhea. Congenital cryptomenorrhea. Now, this you already know that it is imperforate hymen or hematocolpos or congenital cryptomenorrhea. Fine, all of you are correct. Now, my question is, what is your next step in management? You have already made a diagnosis of imperforate hymen. Is it a hormonal profile, ultrasound, karyotyping, or you jump onto the laparoscopy? ऑब्स गाइनी में एक ही तो इन्वेस्टिगेशन है, नॉन इन्वेजिव कहीं पे भी फिट कर दो. सो इट्स ऑलवेज अल्ट्रासाउंड. व्हाई इट इज नॉट हार्मोनल प्रोफाइल? सी, hormonal profile is not the answer. This is not primary ovarian failure. This is not Turner syndrome, because in both cases FSH LH will be high. That is never our first investigation. Plus, why not karyotype? Karyotype is always confirmatory, and here if you get karyotype done, it is 46XX. You will not come to know that uterus is present or absent, because in cryptomenorrhea uterus is present and karyotype is same. If it is some other problem like primary ovarian failure or something other, then again karyotype will be the same. So uterus present है कि absent है वो कैसे देखें? It is by ultrasound that you have to check uterus is present or absent. So answer to this question is ultrasound. Now, what is the treatment for imperforate hymen? It is cruciate incision and drainage. Now, what is the another advantage of getting ultrasound done? You know, ultrasound you will check genitourinary anomalies as well. With ultrasound, you can check genitourinary anomalies as well. Genitourinary anomalies as well. Okay, because there can be ectopic kidney, there can be horseshoe shaped kidney, etc. Next, 18-year-old girl presented with primary amenorrhea, breast development is normal and axillary pubic hair are absent. Breast normal, axillary pubic hair absent, bilateral inguinal hernia, absent uterus. What is it? Excellent. It is androgen insensitivity syndrome. Okay. It is androgen insensitivity syndrome. Karyotype is 46XY. Breast development is normal, but axillary hair and pubic hair are absent. Why? Because testis is undescended testis. That is what inguinal hernia. ठीक है? Testis is in the inguinal region and the external genitalia is female. External genitalia is female and the breast development is absolutely normal. So what happens? Testis is secreting enough testosterone, rather high testosterone, but it does not get converted into its active form dihydrotestosterone because of defect at receptor level. So this testosterone gets converted into estrogen. Normally, the Leydig cells intrauterine life में testosterone secrete करते हैं, and testosterone is responsible for external genitalia formation in the male child and internal genital organ formation in the male child. अगर testosterone is not functioning तो external genitalia क्या बन जाएगा? Female. अब external genitalia female है, ठीक है? External genitalia is female. Female external genitalia. Now there is no scrotum. So where will the gonads descend? So that is why gonads will remain in the inguinal region. But this undescended testis is a risk factor for testicular tumors. You can't treat amenorrhea because uterus is absent in them and you can't transplant uterus. So what is the treatment? At least save the patient from testicular tumors. So gonadectomy is the treatment. And you give estrogen to maintain the feminism because feminine body figure has to be maintained. क्यों? क्योंकि baby has grown up as a female. She has developed breast at puberty, body is feminine body figure and genitalia is female. तो उसको तो female ही पता है. अब suddenly you tell you're a male, will have so much of psychological problems. So let her live like happily as a female. Gonads you have to take it out. And she will never be able to conceive and she will never be able to menstruate because uterus is absent. Okay. तो ट्रीटमेंट क्या है? गोनेडेक्टमी. वो हमने क्यों किया? बिकॉज टू सेव द पेशेंट फ्रॉम टेस्टिकुलर ट्यूमर्स. दैट इज व्हाई. बट एमेनोरिया वी कैनॉट ट्रीट बिकॉज यूट्रस वी कैनॉट इम्प्लांट, ओवरीज वी कैनॉट ट्रांसफर. ओके, बट व्हाई यू आर गिविंग ईस्ट्रोजन? सो दैट शी मेंटेन्स द फेमिनिन बॉडी फिगर. दैट इज. I hope things are very clear to you. Absolutely. I'm just explaining at a stretch so that thoda sa bhi twist hua question mein you are able to get your answers. Fine. So it's clear. Happy with your responses. Next. 19-year-old girl, primary amenorrhea, breast normal, axillary pubic hair normal, ultrasound shows absent uterus. Straightforward question. What is being done wrong here is the options किसी दूसरे questions के डल गए हैं. So कोई बात नहीं. This is, I am not taking your exam. This is not, you know, like कि चलो तुम्हारा FMG एग्जाम हो गया, अभी तो बचा हुआ है, एक ही तो सब्जेक्ट कर रहे हैं हम. अब मैं ऑप्शंस लिख रही हूँ प्लीज. एंड्रोजन इंसेंसिटिविटी सिंड्रोम, एंड्रोजन इंसेंसिटिविटी सिंड्रोम, टर्नर सिंड्रोम, मुलेरियन एजेनेसिस. सो व्हाट इज योर आंसर? मुलेरियन एजेनेसिस. Excellent. What is the karyotype? 46XX. What is the gonads? Ovaries. And breast development normal, axillary pubic hair normal. So I hope it's been very clear to you. I am discussing each and every syndrome. Primary ovarian failure, menopause, Asherman syndrome, testicular feminization, Turner syndrome, Mullerian agenesis. So every part of it has been discussed. That was the aim. Now, 16-year-old girl presented with primary amenorrhea, breast normal, Tanner stage 1. That is, breast development is not up to the mark. What is Tanner stage? Till 5. It is 1. So, axillary pubic hair are present, height is normal, uterus is present, FSH, LH elevated, and ultrasound streak gonads. Can you judge what is the answer? एक second. Listen to me first. In Turner syndrome, is height normal? Short stature. In the previous questions, I mentioned Swyer syndrome is streak gonads. So, this is 46XY. For the time being, if you are able to understand this question, fine. Otherwise, this is little bit difficult for you. It's a PG level question. Okay. कोई बात नहीं, अगर आपको क्लियर है तो ठीक है, अदरवाइज सबसे पहला डिफरेंस, व्हाई इट इज नॉट टर्नर, बिकॉज हाइट इज नॉर्मल. नंबर 2, streak gonads, so this is Swyer syndrome. Fine. Why it is not Kalaman syndrome? Because they have not written anosmia. Anosmia लिखे होगा तो लिखेंगे Kalaman syndrome. चलिए next. 28-year-old woman comes for the treatment of hirsutism. She is obese. She has facial acne. Serum LH is 32. FSH is 9. Which of the following is most appropriate? First of all, tell me, is it that given in the option PCOS? No. That's your diagnosis. PCOS is your diagnosis. Agreed. Why? She is obese. There is hirsutism. There is acne. And menstrual disturbance they have not written, but they have mentioned FSH-LH ratio being altered. FSH-LH ratio is altered. So this is hirsutism, acne, and might be some menstrual disturbance in this female. So most common cause for hirsutism in a young female is PCOS, provided other causes you've ruled out. What is a close differential diagnosis? Congenital adrenal hyperplasia, late onset. But that is pre-pubertal hirsutism. Okay. So that does not fit into this category. Now, this is hirsutism, acne, altered FSH-LH ratio, menstrual disturbance not mentioned in the question, but your diagnosis is PCOS. Now, what is the treatment you are going to give? Oral contraceptive pills. If in the question a term like lifestyle modification is written, then I would have marked lifestyle modification as my first line of management. If lifestyle modification is not written, then I go to the second line of management, which is drugs. And which is a drug that is given to treat menstrual disturbance, to treat LH-FSH ratio alteration, to treat hirsutism, to treat acne. The one and only one answer is OCPs. Why? Because OCP will correct the menstrual disturbance and OCP increases the sex hormone binding globulin. So if sex hormone binding globulin is increased, the free testosterone levels will down because it will get bound to the sex hormone binding globulin. So hirsutism will get correct. Hirsutism will get corrected. Acne will get corrected. And menstrual disturbance भी correct हो जाएगी. एक ड्रग जिससे हिर्सुटिज्म करेक्ट हो, एक्ने करेक्ट हो, मेंस्ट्रुअल डिस्टर्बेंस करेक्ट हो, दैट इज ओरल कॉन्ट्रासेप्टिव पिल्स. कौन सी वाली? द वन विच कंटेन्स थर्ड जनरेशन और फोर्थ जनरेशन प्रोजेस्ट्रॉन. थर्ड जनरेशन इज डेसोगेस्ट्रॉल, fourth generation is drospyrinone. Third generation and fourth generation progesterone. Mala D, Mala N are levonorgestrel containing progesterone or OCP. That will not be so useful as third and fourth generation OCP. ठीक है? I hope it's clear. अगर इसमें ये होता insulin resistance, obesity, menstrual disturbance, what will be the drug? Metformin. If it is unmarried girl and secondary amenorrhea, क्या ड्रग होती? प्रोजेस्ट्रॉन. अगर यही इनफर्टिलिटी होता, क्या ड्रग होती? लेट्रोजोल और क्लोमिफेन सिट्रेट. सो सिमिलरली विल बी योर आंसर्स. Question of FMG exam. I hope you want me to tell which was the FMG exam questions out of this, so that when you are revising, giving a final touch before your exam, you are revising this. ये TND तो रिवाइज करके जाना है, ठीक है? This is important. So 32-year-old female, amenorrhea galactoria. What is the likely cause? Amenorrhea, galactorrhea. What do you expect? Serum prolactin levels are high. That is, the defect or the cause is at the level of pituitary. It can be hyperprolactinemia. It can be prolactin secreting pituitary tumor. So the problem is at the level of pituitary. How serum prolactin levels affect? Serum prolactin, if more than 25 nanogram per ml, this leads to suppression of FSH and LH. This leads to suppression of ovaries and ovulation. Treatment or drug of choice for, let me write the question first, hyperprolactinemia. Excellent answer. Cabergoline. Drug of choice for hyperprolactinemia with infertility due to anovulation. Infertility due to anovulation, answer is bromocriptine. ठीक है? If it is just hyperprolactinemia, then your drug of choice is cabergoline. If it is hyperprolactinemia leading to infertility, leading to anovulation, then your answer is bromocriptine. Why? It is advised to give bromocriptine at bedtime. Yes, because the most common side effect of bromocriptine is postural hypotension. Most common side effect of bromocriptine is postural hypotension. So this is something important. Now, spot out the wrong statement in PCOS. Excellent. देखो, दो तीन चीजें बिल्कुल ध्यान से सुनो. If you have a patient where hirsutism is given, क्वेश्चन में hirsutism में, what is your first investigation to be done? Answer is serum testosterone. सबसे पहली इन्वेस्टिगेशन क्या कराते हैं? सीरम टेस्टोस्टेरोन. In PCOS, serum testosterone levels are elevated, but it is between 70 to 200 nanogram per ml. But when it is adrenal tumor or androgen secreting ovarian tumor, if it is tumor, then the serum testosterone levels may increase to 200 nanogram per ml. Serum testosterone levels will increase to more than 200 gram per ml. ठीक है? So I hope it's clear. इसमें PCOS में कभी भी 200 नैनोग्राम से ज्यादा नहीं होता टेस्टोस्टेरोन. ठीक है? Then E to E1 ratio is decreased in PCOS, correct. LH to FSH is increased, this is correct. Fasting insulin is increased, this is also correct. Okay. So the wrong answer here is serum testosterone. 30-year-old lady presented with secondary amenorrhea for 8 months. She has heavy blood loss after delivery. She received blood transfusion. What do you think the likely cause for secondary amenorrhea? It is Sheehan syndrome, because this is postpartum pituitary necrosis. postpartum pituitary necrosis, that is Sheehan's syndrome. Postpartum pituitary necrosis, that is Sheehan's syndrome. Failure to lactate, decreased BMR, secondary amenorrhea, alopecia, etc. Now, what is the treatment for Sheehan's syndrome? You have to treat the stress. So, that is give cortisol and give thyroxine for lifelong. Why you have to give cortisol and thyroxine? Kyun? Because when pituitary has undergone necrosis, anterior pituitary hormones are down. Okay, so let me clear what are the features for Sheehan's. It is failure to lactate, secondary amenorrhea, decreased BMR, cold intolerance, lethargy, weakness, alopecia, loss of axillary hair and pubic hair. There may be hypotension, there may be diabetes, etc. Failure to lactate because of prolactin deficiency, decrease FSH and decrease LH because of that secondary amenorrhea, decrease TSH because of decrease leading to decrease BMR, alopecia, this is decrease in ACTH. जब ये सारे हॉर्मोन्स डिक्रीज्ड हैं, हमें कौन सा ट्रीटमेंट करना है? ऑलवेज इंप्रूव अपॉन बेसल मेटाबॉलिक रेट एंड एंटी स्ट्रेस हार्मोन. तो आपको कॉर्टिसोल एंड थायरॉक्सिन देना है लाइफ लॉन्ग. दिस इज व्हाट इज द ट्रीटमेंट फॉर शीहैन्स सिंड्रोम. ठीक है. एमेनोरिया इफ यू वांट टू ट्रीट, आप उसको ईस्ट्रोजन प्रोजेस्ट्रॉन दे सकते हो इफ यू वांट टू ट्रीट एमेनोरिया. ठीक है. बट डू यू थिंक treating amenorrhea is more important than treating the stress? Stress hormone and thyroxine is most important to treat Sheehan's syndrome. ठीक है. But इस type के questions should come in FMG because there is a direct hint in the questions. Okay, they are giving you hint in these questions that you are able to find out. Secondary amenorrhea after a history of PPH, ब्लड ट्रांसफ्यूजन भी चढ़ गया यानी सिवियर एनीमिया हो गया, तो एंटीरियर पिट्यूटरी अंडरवेंट नेक्रोसिस. ओके. नेक्स्ट क्वेश्चन. ऑल ऑफ दिस कैन अकर इन दिस केस एक्सेप्ट गैलेक्टोरिया कैनॉट अकर because galactoria will have increased prolactin. What we are talking about? Decreased prolactin. Galactoria will develop because of increase in the prolactin levels. Next. Name the classification used for hirsutism. Ferryman-Galway is for hirsutism. Ferryman-Galway classification is for hirsutism. Page's classification is for abruptio placentae. Abruptio placentae. Tanner's classification is for puberty changes. Puberty changes like breast development and axillary hair, pubic hair development. Quintro's classification, twin transfusion syndrome. कोई बात नहीं, आप इसमें मेन याद रखो, पेजेस क्लासिफिकेशन, टेनर्स एंड फेरीमैन-गैल्वे. नेक्स्ट. दिस इज फेरीमैन-गैल्वे क्लासिफिकेशन. कैन यू सी द हेयर ऑन द लिप्स, चेस्ट, चिन, लोअर एब्डोमेन, आर्म्स, लेग्स? दिस इज hirsutism. Hirsutism features are whenever the androgens are increased. androgens are increased in the female, because in the males already androgens are high. That is why there are puberty changes in boys. Fine. But when androgens increase in the girls, features of hirsutism will appear. Okay. Features of hirsutism will appear. Virilization is defeminization. Change in the voice of the female just like male. Atrophy of the breast, muscular body and secondary amenorrhea. This is virilization apart from hirsutism. More severe form of hirsutism is virilization, you can say. Androgen secreting ovarian tumor causes virilization. Androgen secreting adrenal tumor can cause virilization. PCOS causes hirsutism, not virilization. 30-year-old female complains of increased facial hair and oligomenorrhea for 6 months. What is the first investigation? Testosterone. First investigation is testosterone. Next. Which of the following is absolute contraindication for IUCD insertion? Undiagnosed uterine bleeding. Okay. Rest you can apply IUCD. It is not contraindicated. Most common cause of rapid onset of hirsutism. CAH, late onset. Congenital adrenal hyperplasia, that is late onset. 28-year-old married female has PCOS. Now she develops infertility and report shows anovulation. Semen analysis is normal. What is a drug to treat infertility in this case? Infertility, ovulation induction. So, the first choice is letrozole, then clomiphene citrate. Letrozole, then clomiphene citrate. Letrozole, what is letrozole? It is aromatase inhibitor. Both of them cause and decrease the estrogen levels. They act as an anti-estrogen. Now letrozole is our first choice. Letrozole is our first choice, then the clomiphene citrate. A lady with infertility undergoes laparoscopy for the purpose of assessment. Okay. Tubal patency test involve pushing a dye through a cannula into the fallopian tubes via uterus. This chromotubation is done by which dye? Methylene blue dye test. Okay. Methylene blue dye test. So, first of all, you are doing HSG. And what is the cannula used for HSG? It is Leach-Wilkinson cannula. HSG, what type of dye we are using? Radio opaque dye. What is the name of the dye? Urographene. Urographene dye. And if there is any tubal block on HSG, it needs to be confirmed on laparoscopic chromotubation. It needs to be confirmed on laparoscopic chromotubation. So what is a dye used for laparoscopic chromotubation? Is methylene blue dye. Now, my question is that you have a patient where HSG was done followed by laparoscopic chromotubation and it shows bilateral tubal block. What is your best management in this case? Answer is IVF. Best management is in vitro fertilization. Another question. If there is HSG showing bilateral tubal block, what is your next line of management? Tubal block on HSG, what is your management? Tubal block on laparoscopic chromotubation, what is your management? If it is tubal block on laparoscopy, that means you have already confirmed it is a tubal block. Then answer is IVF. If it is HSG showing tubal block, then you need to confirm it. Then you mark your answer as laparoscopy. After HSG, it is laparoscopy. After laparoscopy, it is IVF. So, after HSG, go for a laparoscopy. After laparoscopy, if tubal block, go for IVF. Don't jump to IVF after HSG finding. If suppose on a peripheral smear, there is blast cell, will you give the treatment for leukemia? No. You have to do bone marrow to check for the type of leukemia. Then only you can give the treatment. Is it AML, CML, ALL? What is it? Accordingly, you will give the treatment. Fine. Next. 22-year-old female was using OCPs for contraception and she's been diagnosed with TB. Doctor wants to start ATT. Which drug interaction will come to your mind? Rifampicin. It is rifampicin. Has a drug interaction. So there will be failure of contraception. Failure of contraception. Rifampicin, there will be failure of contraception. It's not about toxicity. It's that there is a drug interaction with rifampicin. So you have to remember anticonvulsant drug, there is drug interaction. Okay. Now, this test is done in a woman investigated for infertility. What treatment you will offer to this patient? Dekho. If, just listen to me, if it is genital TB, if it is genital tuberculosis, which is also one of the important topic in gynae, genital TB, 90% cases occurs in fallopian tube leading to infertility. 50% cases it occurs in the uterus leading to infertility or leading to menstrual disturbance. Okay. Now, if it is genital tuberculosis, first line treatment is you will start ATT, anti-tubercular treatment, depending upon 6 months or 9 months. Fine. Then she has come to you with the treatment of infertility. You know you have to go for IVF because tuberculosis permanently damages the fallopian tube. And even if she is trying for a pregnancy, she will land up in infertility or ectopic pregnancy because tuberculosis permanently damages the fallopian tube. तो जो ट्यूब के सीलिया होते हैं वो परमानेंटली डैमेज हो जाते हैं, तो डिफिकल्टी इन अचीविंग प्रेगनेंसी, और अगर हो भी गई तो सीलिया डैमेज्ड हैं, यहाँ पे फर्टिलाइज्ड ओवम विल स्टे एंड इट विल लीड टू एक्टोपिक प्रेगनेंसी. सो वी हैव टू बाईपास द ट्यूब्स by doing IVF. But for IVF, you need to check uterus is normal or not. How will you check? Hysteroscopy. Okay. So the correct answer is ATT, hysteroscopy and IVF. Why I have written hysteroscopy in the middle? Because सबसे पहले आप uterus check करोगे तभी तो IVF करोगे. After IVF you can't check the uterus ना. Because IVF is a costly technique. Okay. तो यू शुड चेक इम्प्लांटेशन इज पॉसिबल और नॉट. एटीटी से ट्रीट कर दिया, ठीक है, हिस्ट्रोस्कोपी करके चेक करो, अब आईवीएफ कर दो. सो यू हैव टू अप्लाई द कॉन्सेप्ट. Those who are thinking of just IVF is a wrong answer. You have to treat tuberculosis first. Then, those who are thinking hysteroscopy and laparoscopy, again of no use. Okay, what do you gain by doing laparoscopy? Are you checking for endometriosis? That's why you're doing laparoscopy. In the question they have already given. In MCI till today, 2 associated question has not been asked. This is just to build up concept. 2-4 क्वेश्चन मैंने एसोसिएटेड इसलिए रखे हैं ताकि आप कॉन्सेप्ट्स के थ्रू नेक्स्ट क्वेश्चन सॉल्व करो. बट 2 एक से क्वेश्चंस नहीं आएंगे, जस्ट 1 क्वेश्चन विल कम. नेक्स्ट, 32-year-old female, P2L2 come 4 days after unprotected coitus, asking for contraceptive advice is copperty. Because this is, yes, because hormonal treatment can be given for 3 days. Now post-coital contraception, it is hormonal, to be given within 72 hours of unprotected coitus, or it is IUCD, to be given within 5 days of unprotected coitus. Now in the hormonal, it is LNG pill, which is 1.5 milligram single dose. Number 2 is OCPs, 4 tablets, and after a gap of 12 hours, 4 tablets. Number 3, it is RU486. Among the IUCD, it is copper T. Okay, this is emergency contraception. Now, question of an exam 2022. Which is the most commonly given emergency contraception in India? Emergency contraception in India. Always your answer is levonorgestrel pill. Most commonly. Number 2. Which is the best emergency contraception? It is copper T. Best emergency contraception is copper T because you do not know this act of coitus has led to fertilization or not. Even if fertilization has occurred, copper T prevents implantation. ठीक है, सो emergency contraception में best क्या है? Copper T. Most commonly given क्या है? LNG pill. LNG pill, POP pill नहीं बोलना है इसको, LNG pill. POP pill is for contraception. ठीक है, and that is called as mini pill. Okay, now there is another emergency contraception with the name of ulipristal. This is selective progesterone receptor modulator, and its 30 milligram is the dose within 5 days of unprotected coitus. Okay, 30 milligram is the dose. Ulipristal, most of the time in FMGE exam they don't give as such, and ulipristal is again not available freely. ठीक है. Next, all of the following are LARC contraceptives except long-acting reversible contraceptives are DMPA injection, Implanon, and IUCDs. So the wrong answer is progesterone only pill is not LARC contraceptive. ठीक है, अगर इसमें OCP लिखा होता तो वो भी LARC contraceptive नहीं है. ठीक है, अगर पोस्ट क्वाइटल कॉन्ट्रासेप्शन में मायरीना लिखा होता, विल यू राइट इट इज एन इमरजेंसी कॉन्ट्रासेप्शन? नो. इफ इट इज रिटन एज मीजोप्रोस्टॉल, will you write an emergency contraception? No. Will it written as danazole? Will you write emergency contraception? No. So Mirena, danazole, misoprostol are not emergency contraceptives. ठीक है, LARC contraceptive में IUCD, Implanon and DMPA injection ही आएगा. Okay. Next. A female came to you asking for contraceptive counseling. She had childbirth 1 year back. So we'll follow the sequence. You can search the question and we'll do it. Otherwise, questions बीच में छूटते जाएंगे. Now, there is asking for a contraceptive advice and childbirth was 1 year back. All of the following histories are important before you do IUCD insertion. Which history is not important? Excellent. It's an excellent answer from all of you because PID, STD, undiagnosed uterine bleeding, previous ectopic pregnancy, these histories are important because absolute contraindication for IUCD. Most appropriate answer. If it is MTP in the past, MTP के साथ तो कॉपर्टी लगाते ही हैं. Normally what we do in family planning OPD or OT, MTP with copper-T insertion is done for those who want spacing. ठीक है, MTP के साथ हम copper-T insertion करते हैं. So D is the answer for this question and it is excellent reply. Next. This is again an FMG exam question. A woman after hysterectomy develops distended abdomen. Which electrolyte balance is seen? Hypokalemia is the answer because this is paralytic ileus, which usually develops after surgery. So this is clear-cut answer. 25-year-old girl came giving history of sexual assault. She is wanting an emergency contraception within 8 hours. She is on 3rd day of the cycle. What will you give? Done? See, is DMPA an emergency contraception? No. Will you wait till she gets periods and then you will start OCP? Is she asking for a contraception? She has been a victim of sexual assault. It's a rape. And she is on 13th day. Immediately give her levonorgestrel pill. What she is requiring? Emergency contraception. Will you wait till she gets pregnant and then you will start? You will think of doing MTP. You will give immediately the levonorgestrel pill. Okay. And misoprostol is again not an emergency contraception. I just mentioned in the previous question. ठीक है? ये question I have just created to build up the concept. भाई, LNG pill लिख के आना है. Are they going to ask you? बच्चों बताओ. What is the emergency contraception commonly given? LNG pill, you know it. But how to apply that in the question is what is a practice. I have designed this question myself just to create कि कहाँ पे आपको emergency contraception लिख के आना है. This is what is the answer. DMPA and misoprostol तो पहले ही हट गया, वो emergency contraception है ही नहीं. ठीक है? And OCP from next cycle अभी 13th day है. अभी इतने सारे दिन वो wait करेगी? No, because that time implantation will occur. Got it? Next, 35-year-old patient brought to gynae casualty and collapsed. Whenever the term brought is written, that means general condition is not good. She is collapsed. And there is a history of amenorrhea, 1.5 months, that is 6 weeks amenorrhea. Bleeding per vaginum. She is in shock. Amenorrhea, bleeding, shock. Ultrasound done. No gestation sac in uterus. That means empty uterus. Free fluid in pouch of Douglas. This is ruptured ectopic. And which type of rupture? Which type of rupture? Ischemic rupture. Which type of ectopic pregnancy ruptures earliest? Ischemic. in less than 6 weeks. Just read the question once more. Amenorrhea is 1.5 months, that is 6 weeks. And in 6 weeks pregnancy, she has come in shock, fainting, amenorrhea, bleeding PV, ultrasound, empty uterus, diagnosis, rupture ectopic, management, resuscitation and immediate laparotomy and salpingectomy. So the answer is immediate laparotomy. Do not write laparoscopy. Usually for shock patients, laparoscopy is not recommended. So this is rupture ectopic and your management is resuscitation and immediate laparotomy. Resuscitation and immediate laparotomy is the answer, followed by salpingectomy. So which type of ectopic pregnancy ruptures earliest? Ischemic. Which type of ectopic pregnancy ruptures late? Interstitial. Interstitial ectopic ruptures late. Question. What is the drug of choice for medical treatment of unruptured ectopic? Methotrexate. For unruptured ectopic, the medical treatment is methotrexate. Can you tell me what is the gold standard treatment, gold standard investigation for ectopic pregnancy? Is laparoscopy. Gold standard investigation for ectopic pregnancy is laparoscopy. Why do we call it as gold standard? Because you will confirm your diagnosis and you can treat. Okay, you can confirm your diagnosis when the diagnosis is under suspicion. Matlab you are not clear, it is ectopic or it is not ectopic. And then you can treat your patient simultaneously. So the gold standard investigation for ectopic pregnancy is laparoscopy, diagnostic as well as therapeutic. Laparoscopy. Laparotomy, the question we have just discussed. If it is rupture ectopic, it is laparotomy. If it is unruptured ectopic, it is laparoscopy. Most common site for ectopic. Okay. I am changing your question. Most dangerous type of ectopic pregnancy. Interstitial. Why? Because the ectopic pregnancy is here and it will get embedded in the uterus. So very unlikely that you will pick up it in time. It will get missed out, and by the time you diagnose it, it might be ruptured, and the vascularity of this part is high and you'll end up doing hysterectomy at times. Most common site for ectopic pregnancy, fallopian tube. Which part of the tube? Ampulla. Earliest to rupture, ischemic. Late to rupture, interstitial. Most dangerous, interstitial. Type of ectopic pregnancy and criteria. Ovarian ectopic, Spiegelberg. Primary abdominal, Study Ford. Cervical ectopic, Rubin's. So, till now, it is not in my knowledge that any question being asked in FMG on criteria. This is usually asked in PG. But we have discussed Spiegelberg, Studiford, and Rubin's criteria. Management of rupture ectopic pregnancy. Important is you have to go for immediate laparotomy, resuscitation, and immediate laparotomy. Best non-invasive investigation for ectopic TVS. Gold standard investigation, laparoscopy. Dash is used for ectopic pregnancy follow-up. Beta HCG. Okay. Okay, I'll ask you a question. Which type of ectopic pregnancy cases have reported the baby has grown till term? Secondary abdominal. Abdominal नहीं बोलना, secondary abdominal ectopic pregnancy. Because abdominal में तो primary भी आता है. Got it? Next. Criteria for giving methotrexate for unruptured ectopic. Size less than 4. Cardiac activity should be absent. This is very important criteria. And beta HCG should be less than 5000. Hemodynamically, patient should be stable. It is not unruptured and family not complete. In that case, it is a conservative management and you can go for a methotrexate. Okay. Size of the ectopic. Why I mentioned this? In FMGE exam, they have asked a question on the criteria as well. Don't think it's not important for us. It is important for you. If I ask you what is the most important feature for giving methotrexate is cardiac activity should be absent. सबसे important क्या है? वैसे तो सारे important है. Size, cardiac activity, hemodynamically stable and beta HCG. All are important. One single feature which is most important is cardiac activity should be absent. Ring of fire sign in adnexa. Excellent. This is Doppler finding. This is ectopic pregnancy. Ring of fire sign in adnexa on ultrasound Doppler is a feature of ectopic pregnancy. Okay. Question of FMG exam. Double decidual sign is a feature of normal intrauterine pregnancy. Double decidual sign on ultrasound is a feature of normal intrauterine pregnancy. Okay. Identify this procedure. Culdocentesis, diagnosis of ruptured ectopic pregnancy. Diagnosis of ruptured ectopic pregnancy. The type of Mullerian duct anomaly that can cause unilateral dysmenorrhea in rare chance ectopic pregnancy does not have a good reproductive outcome. Name the anomaly. I have given you 3 hints in this question. If still you are not able to mark it, can't help it. What was asked in FMG exam? Not the question. HSG image. There was an image, cannula. Identify the image was the question in your exam. But this question I've just created to tell you what are the features of unicornuate uterus. It causes dysmenorrhea. How? See, both Mullerian ducts fuse to form single uterus tubes, cervix and vagina. If one horn remains there and from another horn the uterus is developing and fallopian tube is developing. This is unicornuate uterus. If there is endometrium here and this horn is communicating with uterus, okay, this fertilized ovum can stay there, leads to the chance for ectopic pregnancy. If अगर ये हॉर्न कम्युनिकेट कर रहा है तो यहां एक्टॉपिक प्रेगनेंसी हो सकता है. अगर ये कम्युनिकेट नहीं कर रहा है तो फिर क्या होगा? एंडोमेट्रियम यहां पे भी है, एंडोमेट्रियम यहां पे भी है, यहां की तो शेडिंग हो गई, मेंस्ट्रुएशन, यहां का एंडोमेट्रियम यहीं रह गया, लीडिंग टू यूनिलैटरल डिस्मेनोरिया. एंड if there is a unicornuate uterus, how does the uterus enlarge to continue the pregnancy? Because it is just half uterus which is formed, so has a poor reproductive outcome. Which type of Mullerian duct anomaly has a best reproductive outcome? Arcuate uterus. Arcuate uterus has got a best reproductive outcome. This is arcuate uterus, just a dome-shaped depression. Which is the most common Mullerian duct anomaly leading to infertility or abortions? Septate uterus. So I hope it's clear. HSG image showing unicornuate uterus, question of FMGE exam. This horn is not connected to the rest of the cavity. There is dysmenorrhea. If it gets connected, it is ectopic pregnancy. This is just explanatory slide. This is classification. Classification of Mullerian duct anomalies. Usually they ask septate uterus is which category of Mullerian duct anomaly? So it is category 5. You can read this. Till today there is no question being asked on the classification in FMG. Till today I said. Routine screening is not done for which cancers? ये दोनों आंसर है, लेकिन in FMG there will be just one answer. So either they will write endometrial or they write ovarian. Okay. So in one of the option they can cut the ovarian and write none. Then your answer will be endometrium. Okay. Listen to me first. See, if it is a PG where there are more than one answer, it is two answers. For you, there will be just a question with single answer. So this is the question for you. So what you will mark? Endometrial. If suppose endometrial is not given, ovarian is given, then ovarian is the answer. Routine screening is not done for ovarian as well as endometrial cancer. Routine screening is done for oral, breast and cervix cancer. This is the 3 cancers according to Government of India screening is being done. According to Government of India, screening for 3 cancers is done routinely. For oral, mouth checkup under torch. For the breast, it is clinical breast examination and sometimes screening mammography above 40 years. For the cervix, it is pap smear or HPV DNA test. 49-year-old lady comes to the OPD with irregular menstrual bleeding. She is perimenopausal. Doctor advised screening for cancer cervix. What is this? Excellent. This is VIA. Visual inspection under acetic acid. Okay. And there is aceto-white area. Abnormal area is aceto-white area. Where? Now just listen to me. If there is resource limited countries, VIA is done. This is cost effective mass screening method. Cost-effective mass screening method, where according to WHO, if it is resource rich country, then HPV DNA testing is recommended. If resource rich country, then the screening test is HPV DNA testing. If it is resource limited countries, it is VIA. Presently in our country, what we are doing? We are doing pap smear. But pap smear is a screening test. You need colposcopy as confirmatory. So colposcopy is a specialized thing. Okay. So that is why HPV DNA testing is primary test, better than pap smear. But it is costly. Around 3,000 is the cost. Is it a blood test? No. Just we take it a pap smear. Similarly, we take it a sample from the cervix for HPV DNA testing. Okay. Tell me, HPV DNA testing is to be started from which age group? 30 years of age group. Pap smear can be started 21 years in a sexually active female, but HPV DNA is 30 years of age. Question of FMGE exam 2022. Filter used in colposcopy is a green filter. Filter used in colposcopy is a green filter. This is colposcopy finding using green filter. This is how the image looks like. Colposcopic findings using the green filter. 67-year-old female was biopsied for postmenopausal bleeding and it is showing endometrial adenocarcinoma. She is obese, diabetic. Next line of management. She is diagnosed with biopsy. So you have to give the treatment. It is TAH with BSO. Because it is grade 1. In grade 1, there is no need for any post-operative radiotherapy. Hysterectomy is fair enough. Chances of ureter injury is high in Wardheim's hysterectomy. Chances of ureter injury is high in Wardheim's hysterectomy. 35-year-old female P2L2 CIN3 on colposcopic directed cervical biopsy. What is your next step in management? Simple hysterectomy, cryosurgery, LEAP or conization? LEAP. LEAP is the best treatment for CIN2 and CIN3. LEAP is the best treatment for CIN2 and CIN3. That is, if it can be, the effect can be electrosurgical excision or it can be electrocautery. The effect can be electrocautery or excision. The effect can be electrocautery or it is excision. What is the most common cause for cancer cervix? Most common cause for cancer cervix? HPV 16 and 18. What is the most common type for cancer cervix? Most common type for cancer cervix is squamous cell carcinoma. When there is obvious growth on cervix, What's your next line of management? Yes, it is cervical punch biopsy. Obvious growth on cervix. What is your next line of management? Is cervical punch biopsy. What is the treatment for advanced cancer cervix? Stage 2B, stage 3, stage 4, stage 1B3, stage 2A2. What is the treatment? Concurrent chemo radiation. What is the radiosensitizer drug? Radiosensitizer drug in cancer cervix is cisplatin. Radiosensitizer drug in cancer cervix is cisplatin. So in early stages, you can go for surgery, that is Vardheim's hysterectomy, where apart from hysterectomy, you are removing the pelvic lymph nodes. Or it can be radical hysterectomy where you are removing the para-aortic lymph nodes for sampling. But if it is stage 2B, stage 3, stage 4, stage 1B3 or 2A. Why 1B3 and 2A? Because they are bulky tumors. So they respond better to concurrent chemo radiation rather than going for surgery, because tissues become very, very fragile. Okay. Now, all of the following are screening methods for CIN except, yes, colposcopy is not the screening method. It is confirmatory test. What is used in colposcopy? 3 to 5% acetic acid. What is used in colposcopy? 3 to 5% acetic acid. What is the limitation of colposcopy? Adenocarcinoma cases are missed out. What is the limitation of colposcopy? Adenocarcinoma cases are missed out. Adenocarcinoma cases are missed out because you cannot visualize the endocervix. Which of the following statement regarding cancer cervix is false? Yes. CT scan mandatory for staging is wrong. So, HPV 16-18 are associated, correct. Common at squamocolumnar junction, correct. Postcoital bleeding is one of the commonest presentation, correct. CT scan we are doing or PET CT we are doing just to check how much is the metastasis, how much is the lymph node status, etc. But it is not mandatory for staging, because in cancer cervix staging is the clinical staging, which is important. We do get investigation done, but that is not necessary for staging of cancer cervix. 35-year-old presents with postcoital bleeding. What is your management? It is postcoital bleeding. Postcoital bleeding can be because of cervical polyp also. So visual inspection followed by pap smear is important. Why visual inspection? Because you want to rule out the possibility of cervical polyp. You want to check for any growth on cervix, which can be cancer cervix. Number 3, you want to take pap smear because that is a screening test for cancer cervix. ओके, पर स्पेक्यूलम क्यों जरूरी है? क्योंकि हमें देखना है कि कॉज क्या है. कॉज कैन बी अ सर्वाइकल पॉलिप और इट कैन बी कैंसर cervix. And also when you're doing per speculum examination, do take a pap smear, which is universal screening recommended. ठीक है. universal screening recommended. So correct answer is visual inspection and pap smear. You are not going to do colposcopy. Can you say cervical polyp can never cause postcoital bleeding? Yes, it does cause postcoital bleeding. Although cancer cervix can also cause postcoital bleeding. That is why हम देखना चाहते हैं कि कोई पॉलिप है या ग्रोथ है या फिर सिंपली पैप स्मीयर लेना. So spur speculum is must. Fine. So correct answer is this one. 55-year-old female found to have cancer cervix stage 3B. Important question. So answer is concurrent chemo radiation. Answer is concurrent chemo radiation. 25-year-old female comes for a routine check. 2 vaginal deliveries, no gynae complaints. LMP was 3 weeks ago. You noticed one ovary enlarged 5 centimeters. What's your management? Do CA125. Do diagnostic laparoscopy. Return to check 1 to 2 months. After 2 months for ovaries. Get CT scan done. भाई कुछ तो कैंसर है इसमें. Admit for exploratory laparotomy. चलो laparotomy ही कर लेते हैं. See, let me tell you, she is a reproductive age group female जिसकी 2 normal vaginal deliveries हैं. Periods were normal. Accidentally you notice that there is an ovary enlarged which is 5 centimeters. Now, what are you going to do? Are you suspecting in a 25-year-old any malignant epithelial ovarian tumor? So CA125 is not recommended. Are you going to take her for invasive laparotomy or laparoscopy? No. CT scan कराना है, radiation exposure देना है. क्या आप कैंसर सोच रहे हो? हमेशा unilateral ovarian cyst in a healthy female is benign and it is likely to be follicular cyst of the ovary. Follicular cyst of the ovary when follicle fails to rupture. So just an observation is required. Observation is needed. Now, in this case, you put the patient on follow-up. If the size of the cyst is increasing or it is persisting or it is causing pain, then you can offer her treatment in the form of OCPs or any surgery rarely indicated. So, ये जो cyst है, ये follicular cyst of the ovary है when follicle fails to rupture. तो this is just an incidental finding. इसमें हमें कुछ नहीं करना है. Just keep the patient under observation. Check the size of the cyst or if it is associated with pain or any symptoms or the size increase. 5 का 8 centimeter हो गया. Then you can offer a medical treatment in the form of OCPs to suppress this cyst or rarely surgery is indicated. This question was a question of USMLE series. It was asked in PG exam. Similar question was asked in FMGE exam as well. That is why I have included this question in test and discussion so as to tell you. ठीक है, अगर ओवेरियन कैंसर के ट्यूमर मार्कर्स या हिस्टोपैथोलॉजिकल एग्जामिनेशन आते हैं, दैट्स वेल एंड गुड, सिंगल लाइनर्स जो कि हम डिस्कस कर चुके हैं, बट क्लिनिकल क्वेश्चन इस टाइप से बनेंगे. ठीक है, सिंगल लाइनर यू ऑलरेडी नो, लार्जेस्ट ओवेरियन ट्यूमर, मोस्ट कॉमन ओवेरियन ट्यूमर, क्लिनिकली डिटेक्टेड ओवेरियन ट्यूमर, ट्यूमर मार्कर्स, दैट यू ऑलरेडी नो, that you have to just mug up. This is, you have to apply your concept. Next. Well, frankly speaking, this is an AIMS PG question. 35-year-old female at an axial mass, CA125 slightly elevated, LDH elevated. LDH is the hint. What is this image? Image तो समझ नहीं आ रही, लेकिन क्वेश्चन समझ आ रहा है. LDH. LDH is a tumor marker for Papillary serous cyst adenocarcinoma, teratoma, dysgerminoma, choriocarcinoma. Answer is dysgerminoma. The tumor marker for dysgerminoma is LDH and alkaline phosphatase. It is a radiosensitive ovarian tumor. Radiosensitive ovarian tumor. Which part of the female genital tract is highly sensitive to radiation? Ovary. Ovary is highly sensitive to radiation. See, this is just, like dysgerminoma. This was a question which was asked in a PG exam, where the specimen was given and where the histopathology was given. But from the histopathology and specimen, nothing is clear to me. What is a hint in this question is a tumor marker. So LDH is a tumor marker, you have to get it. इमेज हमको समझ आ रही है नहीं आ रही है कोई बात नहीं, लेकिन क्वेश्चन तो समझ आ रहा है. LDH किसका ट्यूमर मार्कर है? डिसजर्मिनोमा का. सो दैट इज द आंसर. पेपिलरी सीरस का ट्यूमर मार्कर क्या है? CA125. लेकिन LDH तो नहीं होता ना. कोरियोकार्सिनोमा का ट्यूमर मार्कर क्या है? HCG. वो तो नहीं लिखा ना क्वेश्चन में. दैट इज हाउ वी हैव टू गेट द हिंट इन दीज क्वेश्चंस, वेयर सम हिंट और द अदर. Liver or spleen parenchyma involvement in cancer ovary is which stage of ovarian tumor? 4B. It is distant metastasis. Inguinal metastasis. 4B. I have discussed in the class that inguinal lymph nodes is the lymphatic drainage area of the vulva, not the ovary. All of the following are true about borderline ovarian tumors except metastasis common is a wrong answer. There is absence of stromal invasion, true. 10% of epithelial ovarian tumors are borderline, true. Good prognosis, that is also true. But metastasis common is wrong. Metastasis is not common, it is very rare. 10-year-old girl presents with mass in the lower abdomen including umbilical and hypogastrium. On examination, it is cystic and mobile. And examiner is not able to insinuate the fingers in the pelvis. So that means there is some mass arising. And if this is the symphysis pubis and there is a mass which is cystic, I am not able to insinuate my fingers inside. That means mass is arising from the pelvis. Okay. It is not the small intestine duplication, because in that case it will be related to the abdomen. Okay. That is not the case. It is not omental cyst which will be somewhat here. Okay. It is not mesenteric cyst as well. So it is an ovarian cyst which can occur even in young girl. This can be a dermoid cyst. This can be a dermoid cyst. So the answer is ovarian cyst in this question. Again, this question I have just added to create that if a clinical question is being asked, how you are going to get your answer. Since if you are not able to put your hand below the symphysis pubis, that means the mass is arising from the pelvis. That is what it means. It is an ovarian cyst. Ulipristal is aromatase inhibitor, selective estrogen receptor, selective progesterone receptor modulator. Okay. So ulipristal is selective progesterone receptor modulator. Its use is, it is postcoital contraception. Postcoital contraception, and it is used in fibroid uterus. It shrinks the size of fibroid because it is a hormone that is selective progesterone receptor modulator. So it is shrinks the size of the fibroid if given for 6 months or 12 months. All are true about red degeneration of fibroid except occurs during pregnancy, true. Cause is aseptic infarction, true. Admission needed, yes. Surgical intervention done, wrong. We never do surgical intervention during pregnancy. So, this is a pregnant lady with having fibroid and now she presented with pain. So, that is red degeneration. Now, diagnosis can be made by ultrasound or total leukocyte count is raised. What is the management? Again and again they ask this question in FMGE exam. So management of red degeneration of fibroid is always conservative management. Management of red degeneration of fibroid is always the conservative management. And what is this conservative management, students? Admit, put her on bed rest, give analgesics, painkiller because she is in acute pain, and give IV fluids. This is the conservative management and no surgery. So again, this was one of the questions they were interested in asking from you. And students are not able to judge the options unless until you have read about red degeneration. What the student write? Cause is aseptic infarction. You think in terms of pathology. यार ये कहाँ से आ गया गयनी में? And you tend to mark it wrong. So the answer is conservative management. Surgical intervention not needed at all. All of the following are indications for surgical treatment of fibroid except. This is a smart question. Rapidly growing fibroid, what does it mean? Malignant transformation. Is surgical intervention needed? Yes. Pedunculated fibroid. It can undergo twisting. Is treatment needed? Yes. Fibroid causing infertility or recurrent abortions? Yes. But multiple seedling fibroid. यहाँ पे fibroid, यहाँ पे fibroid. अब जब कुछ कर ही नहीं रहा है तो छेड़ना क्यों है? Let it be. Okay. So multiple seedling fibroid treatment is not needed. ठीक है? Why do you want to remove that fibroid? छोटे 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 हैं, रहने दो. But when it is rapidly growing, that means cancer, sarcoma of uterus or leiomyosarcoma. What is the incidence of malignant transformation of fibroid? 0.5%. Risk of malignant transformation of fibroid is 0.5%. This is a rare change occurring in the fibroid. And how do you say fibroid turning into malignancy? Rapid increase in the size. And number 2, worsening of the menstrual cycle pattern. ठीक है? Worsening of menstrual cycle pattern, rapid growth of the fibroid, then you suspect malignant transformation. 28 weeks of pregnant lady comes with acute pain abdomen. Vital stable, CBC shows leukocytosis. All of the following should be kept in the differential diagnosis except red degeneration, twisted ovarian cyst, appendicitis, rupture uterus. Rupture uterus has nothing to do in 28 weeks of pregnancy. Why? There is anything written that she had classical cesarean section done? No. Is it written she is grand multipara? No. So there is no sense of spontaneous uterus to rupture. Why should uterus rupture spontaneously? अगर ये 7th, 8th, 9th ग्रेविडा होती तो हम सोचते, या फिर इसमें ऑब्स्ट्रक्टेड लेबर होता तो सोचते, या फिर कोई प्रीवियस क्लासिकल सिजेरियन होता, वी वुड हैव थॉट. So rupture uterus rules out completely. it can be red degeneration of fibroid, it can be twisted ovarian cyst, it can be abruptio placentae, but or it can be surgical complication like appendicitis, but it can never be rupture uterus. इससे पहले मैं आगे proceed करूं, one question which everybody has a confusion. Actually, the original question was, suppose 40-year-old female has rapid onset of hirsutism. On examination, clitoromegaly, change in voice, that is hoarseness of voice, likely cause. Then the answer is androgen secreting ovarian tumor, because when androgens are in excess in the female, features of virilization will come. Okay? That is virilizing ovarian tumor, features of virilization will come. So complete question is like this, where there is a clitoromegaly, change in the voice of the female, developing secondary amenorrhea and breast atrophy. Okay? These are the features of virilization. Then your answer is androgen insensitivity ovarian tumor. It is really unwise, if not justified, if there is a rapid onset of hirsutism. But what exactly? Okay, so I want, because many of the students are coming and they are saying, because of rapid onset of hirsutism, we have marked the androgen secreting ovarian tumor. Actually, the question which was given or which I have created was exactly like this. But anyhow, rapid onset of hirsutism itself is incomplete question. Do you understand? Complete question ये है, ठीक है? तो अगर खाली rapid onset of hirsutism है, तो congenital adrenal hyperplasia भी थोड़ा incomplete answer है, because congenital adrenal hyperplasia late onset, it presents as prepubertal hirsutism and amenorrhea. ठीक है? कंजेनिटल एड्रेनल हाइपरप्लेजिया लेट ऑनसेट कब लिखना है? जब प्री प्यूबर्टल हिर्सुटिज्म है एंड एमेनोरिया. और एंड्रोजन सिक्रेटिंग ओवेरियन ट्यूमर कब लिखना है? व्हेन दिस काइंड ऑफ हिस्ट्री इज गिवन. बट अगर इनकम्प्लीट क्वेश्चन है तो आई थिंक चेंज कर लेते हैं, फिर हम एंड्रोजन सिक्रेटिंग ओवेरियन ट्यूमर कर लेते हैं. ठीक है? क्योंकि कंजेनिटल एड्रेनल हाइपरप्लेजिया डज नॉट फिट अगेन अगर प्री प्यूबर्टल हिर्सुटिज्म नहीं लिखा है. फाइन, नाउ एवरीबॉडी इज ओके विद इट. ठीक है? Exactly, I have told you what is the way, what are the hints in the question when you have to mark. ठीक है? So for androgen secreting ovarian tumor, this kind of question should be asked, which till today they have not asked from FMG exam, but in PG definitely they have asked. So just to rule out that confusion, most of the time the question given to you is complete form. ठीक है? So let's move further because we have to discuss Obs also and some of the part Gynae which is left. So all of the following are done to reduce the blood loss in myomectomy except, again this is FMG question 2011. So vasoconstrictor, hypotensive anesthesia, GnRH analogs before surgery or OCPs before surgery. What will you think should be the answer? OCPs before surgery is a wrong answer because OCPs do not shrink the size of fibroid. OCP do not shrink the size of fibroid. It is GnRH analogs, danazole, that shrinks the size of fibroid. So what are the drugs that reduce the size of fibroid? Is GnRH analogs, Ru486, ulipristal and letrozole. These are all the drugs that reduce the size of the fibroid. These are the drugs that reduce the size of the fibroid. GnRH reduces or suppresses pituitary, that suppresses the ovary, so estrogen is reduced. So anything that acts against estrogen will reduce the size. Ariphyretic, it is anti-progesterone. Ulipristal, we have just discussed. Letrozole, again aromatase inhibitor. So these are the drugs. OCPs, progesterone do not decrease the fibroid. OCPs, progesterone, Mirena. These are the drugs that do not decrease the size of fibroid. They are given to treat the symptom of fibroid. They treat menorrhagia but do not shrink fibroid. Okay? These are the drugs that treat menorrhagia but do not shrink the fibroid. All of the following are the minimum criteria for diagnosis of PID except pelvic inflammatory disease. What is pelvic inflammatory disease? Pelvic inflammatory disease is an ascending infection. That is infection of upper genital tract in female. Infection of upper genital tract in the female. So infection spreading to the uterus is called as endometritis. Infection spreading to the ovary called as salpingitis. Infection coming to the ovary called as oophorytis. So vagina is resistant to PID. What is the most common causative agent for PID? Chlamydia. Others include gonorrhea, then mycoplasma. These are the causative agents for PID. Okay. So which is not the minimum criteria for PID? Adnexal tenderness, cervical motion tenderness, and uterine tenderness. These are minimum criteria according to CDC guidelines. What is CDC? Center for Disease Control. Okay. ESR and CRP are additional criteria. These are additional criteria. Okay. ESR and CRP are additional criteria for PID diagnosis. Whereas tenderness, जहाँ पे भी tenderness है, that is the minimum criteria for the diagnosis. Which part of female genital tract is resistant to infections is vagina. Vaginitis is STDs except for bacterial vaginosis, but PID में vagina involved नहीं होता because it's an infection of upper genital tract of the female, that is ascending infection. ठीक है. So vaginal epithelium is multi-layered epithelium, stratified squamous. It is not been invaded by these microorganisms. That is why even tuberculosis do not occur in vagina. This gonorrhea, chlamydia do not occur in vagina. ठीक है. Now, this slide is important and you are supposed to read this slide. So it's better that you can click the photo with your mobile and you can write down. Because this explanatory slide which I have typed may not be provided in the question paper. But this is important. Like the extra slides which I have discussed in ectopic pregnancy, you already know the answers. Okay? But this definitely you will have confusion. What is minimum criteria, additional criteria, and definitive criteria? So that it's not that it should remain in your mobile. You should write down in your copy or notes. PID. Fine? So this is something which is important for you. I don't know, question might be asked on this or it is not asked, but it is given in your books. So you should know. Fine? So you can click and later on write down. Next. True about karyotype of complete mole. This has been a PG question in AIMS, but they have asked in FMG. And you have to be very clear what is the answer. Complete mole, first of all, what is the karyotype? Diploid. 90% it is 46XX. Now, what is the, yes, 10% it is 46XY and partial mole is triploid. Now tell me which is the correct answer. Diploid and abnormal chromosomes paternal in origin, diploid and abnormal chromosomes maternal or paternal, triploid or abnormal chromosomes maternal, or it is paternal in origin. So it is diploid and abnormal chromosomes are derived from the father. So normally what happens, there is an empty ovum here. In this case, there is an empty ovum, no chromosomes. It get fertilized by a sperm whose karyotype is 23X. After fertilization, the chromosome of the sperm duplicates upon itself. So, since the fertilization has occurred, so something will be formed that is grape-like vesicles. But this is not going to form the fetus. Why? Because ovum is empty and one set of chromosomes should be derived from the mother and one set of chromosomes should be derived from the father. So what happens? जो sperm के chromosome है वो ही duplicate होते हैं. So that is against nature. So this is called as, like duplication of sperms. So abnormal chromosomes are paternal in origin, derived from the father. So this is the correct answer. Next, 24-year-old primary gravida comes to OPD with bleeding, pain, 2 months amenorrhea, and there is non-tender uterus and it is enlarged to 14-week size and no cervical excitation. Cervical excitation word is used for ectopic pregnancy. So they have ruled out it is not ectopic. So there is amenorrhea, bleeding, enlarged uterus. Uterus enlarged more than the period of gestation. Okay. And there is an ultrasound showing this. What do you see on ultrasound? It is snowstorm appearance. So what is your diagnosis? Diagnosis is H mole. I hope it's clear. So whatever is clear, I am not discussing in very much detail. I have already covered this point. Now what will be the treatment for this case? It is suction evacuation. Now 35-year-old lady was given ovulation induction, beta HCG injection, and she had pain abdomen. Ultrasound shows bilateral theca lutein cyst. Ovulation induction with beta HCG injections. After ovulation induction, there is beta HCG injection given, and now there is theca luteal cyst formed in the ovaries. Now, what will be your management for this case? OCPs, stop all ovulation induction, remove laparoscopically or continue ovulation induction. It is stop all ovulation induction because theca lutein cysts are formed. Theca lutein cysts are formed whenever there is beta HCG stimulation. So when you are giving ovulation induction and trigger the ovulation by giving beta HCG, that leads to theca lutein cyst. If you remove the cause, that is, if you stop the beta HCG or ovulation induction, this cyst will resolve spontaneously. That is what is needed. Now, 38-year-old presented with abdominal swelling for 10 months, urinary frequency menorrhagia, and mass arising from the pelvis, 32-week size and non-tender. Ultrasound was done followed by MRI. What is this which shows in the image? This is excellent answer. Endometriosis never arises in the uterus. Adenomyosis, the size of the uterus is 12 to 14 weeks. It is never 32 weeks. But a big fibroid can be as big as pregnant uterus. So this is no other than fibroid. And when the size of the fibroid is big, maybe after ultrasound you need to get MRI scan done. In this question you can see there's a huge mass like this and bladder is shifted like this. So this is a fibroid uterus typically. Okay. Now what will be the treatment for her? If it is a big size fibroid, I am going to do abdominal hysterectomy because myomectomy will not work. GnRH analogues will not work. And I discussed in my class in gynae, in fibroid, big size uterus cannot be removed by LAVH. Okay, because this huge size uterus, you cannot take it out from the vaginal road. You have to give abdominal incision and take out the uterus. So this is hysterectomy, abdominal hysterectomy. Why? Because size of the uterus is big. That is why. Now, 30-year-old female came to gynae OPD with complaints of vaginal discharge. No evidence of genital ulcer, no symptoms of lower abdominal pain. Which color kit? I have already told you the exam. Yes, excellent. So you can see what type of exam question you are solving. NEET PG, that's great. So this is a green color kit for vaginitis. Gray color kit, that is kit number 1, is for cervicitis. Okay. Then yellow color kit is for PID. That is kit number 6. White color kit is for ulcer, genital ulcer. Yes. Yes, very correct. So you have to know the NACO kits. NACO kits, there are 7 kits. Okay. For the inguinal buboes, number 7, that is black. Okay. So you have to remember the color code kits. So I just cropped the image because I just wanted to mention related to the question. Okay, so it is green color kit. Otherwise, there is white, yellow, blue, red, and this is then black. So you can go for this image. Okay. They have put in different slides. I have given just in one single slide. So you can go through this. Okay, different color code kits. Now, again, match the following is not going to be asked for MCI. Thus, this is just for your practice. Okay, so kit number 1 is for urethral discharge. Kit number 2 is for vaginal discharge. Kit number 3 is for non-herpetic, and kit number 6 for PID. So just have a look what exam question we are solving. Okay, so please, this is just for your practice. This kind of question is not going to be asked, but color code kit they can ask you. Okay. Next, all are correct about bacterial vaginosis except it is not STD, correct. Clue cells are seen, correct. Fishy odor discharge, correct. Plenty of lactobacilli, wrong. Because lactobacilli are replaced by Gardnerella vaginalis. Gardnerella vaginalis. So, lactobacilli will be scanty and the pH will be more than 4.5. What is the criteria used for bacterial vaginosis? Is Emsel's criteria. And you remember there is no itching in cases of bacterial vaginosis, and remember drug of choice is metronidazole. Drug of choice is metronidazole. Fine. But lactobacilli are scanty or absent. That is why the pH will be alkaline, and this infection is favored in the alkaline pH. Fine. Now, which of the following cannot be diagnosed on a wet film? Trichomoniasis, Candida, Chlamydia, Gardnerella, gonorrhea. So, trichomoniasis is motile flagellated microorganism. This is picked up. Candida is, you can see pseudo hyphae in wet film. Gardnerella, you can see clue cells in the wet film. Gonococcus, you can see diplococcus in the wet film. But chlamydia can be only picked up by culture. Chlamydia you cannot see in the wet film. What is a wet film? You have taken the vaginal discharge on a slide and you are putting the cover slip. under normal saline. So this is called as saline microscopy. So in saline microscopy, you can see flagellated microorganism, motile microorganism, that is trichomoniasis, pseudohyphae, gardnerella and gonorrhea. But chlamydia is only picked up by culture. This can be an overlap question between micro and gynae. Correctly, if you ask me, this is micro compared to gynae. Because gynae is more clinical, this is microscopic. Okay. Next. Young female with vaginal discharge per speculum, no discharge on cervix. This TND which we are discussing is your final revision from my side. On this ground, because every topic I have kept plenty of questions for your revision. Okay. This is more than enough. You pick up a topic, read it, solve the questions. Pick up a topic, read it, solve the questions. And whatever we are discussing in the class, that you should remember. Okay. So vaginal discharge. Patient has come up per speculum, no discharge from cervix. So it is not cervicitis. There are two things, either infection in the vagina or gonorrhea and chlamydia infection in the cervix. Okay, so there is no cervicitis, no discharge. So what is the drug you will prescribe? That means you have to give a drug against trichomoniasis, against candidiasis, against bacterial vaginosis. So what is a drug for trichomoniasis and bacterial vaginosis? Metronidazole. What is a drug for candida? Fluconazole. That is how you are supposed to grasp the answer. If you are able to solve like this, that's a challenge. Your question cannot be wrong unless until you want a question to be wrong. बहुत सारे सही कर दिए, चलो एक गलत कर देते हैं. Only then it can be wrong. Okay. So that's how you are going to solve. Even the questions you don't know the answer, rule out. Fine. So cervicitis we ruled out. That means it is not chlamydia, it is not gonorrhea. What are the causative agents for vaginitis or vaginal infection? Trichomoniasis, chlamydia and candida. Drug for candida, fluconazole. Drug for bacterial vaginosis and trichomoniasis is metronidazole. So answer is fluconazole plus metronidazole. Fine? Good. So 28-year-old female with infertility, completely worked up. She's been taken up for laparoscopy. Diagnosis, I've given you laparoscopy image. What is your diagnosis? Hydrosalpinx, normal, endometriomas, ectopic pregnancy. Hydrosalpinx. Can you see the swollen tube on laparoscopy? Swollen fallopian tube. This is a presentation of PID. This is, my dear students, this is PID. Pelvic inflammatory disease, swollen fallopian tube. PID means salpingitis or hydrosalpinx. Next, all of the following are true about genital TB except menorrhagia is seen, infertility is most common, dysmenorrhea is common, menstrual blood can be sent for investigation. Dysmenorrhea is not the complaint of TB. Menorrhagia is seen, infertility is the most common presentation, and menstrual blood can be sent for investigation. So whenever we are suspecting a genital tuberculosis in unmarried girl, we can't do anything. Okay. But we can ask her to collect the menstrual blood and send for the examination. Histopathological finding for tubercular granuloma, PCR for tuberculosis. Okay. So this can also be sent. But as soon as she starts with menstruation, that blood she has to collect, because TB granulomas can shed off within few hours of menstruation. Okay, because we can't do any instrumentation in unmarried girl. So how we are going to make a diagnosis of genital TB? By asking her to send the menstrual blood. Congestive dysmenorrhea usually does not occur in tuberculosis. Not really. Couple came to infertility, HSA was normal, ovulation was normal, HSG shows bilateral tubal block. I have already discussed this question. What is your answer? Laparoscopy. You will not write IVF. IVF is the answer when you have confirmed on laparoscopy. Identify the image. This is hydrosalpinx. This is 2020 exam question. This is HSG image showing bilateral hydrosalpinx. 35-year-old presented with infertility for last 5 years. Ovulation normal, semen analysis normal, ultrasound shows bilateral cyst in adnexa. What is this bilateral cyst in adnexa? I have already made it. We are suspecting endometriosis because endometriosis can be adnexal cyst, that is called as chocolate cyst of ovary. Since this patient has come up with infertility, so laparoscopy is mandatory. With laparoscopy, you will confirm your diagnosis, and with laparoscopy, you can treat the patient. Laparoscopic guided fulguration of the cyst or ovarian cystectomy and break the adhesions. So you can treat the endometriosis via laparoscopy. And after treatment, you give her a benefit of few months that she can try for a normal pregnancy. If she is able to conceive, well and good. If she is not able to conceive, then you can offer her other treatment of infertility. Got it? In suspected endometriosis, the investigation. Can the chocolate cyst ovaries be treated by medical management? This is endometriosis. This is not simple ovarian cyst. So, this cyst, like we can treat it by laparoscopy because she is presented with infertility for 5 years. Giving just ovulation induction will not help in this female. Okay. Most common symptom of endometriosis, again FMG exam question. It is always pain, and if pain is not written, we will write congestive dysmenorrhea. 25-year-old female presented with heavy periods, painful periods, nulliparous, retroverted uterus, tenderness in POD. Heavy periods, menorrhagia. Painful periods, dysmenorrhea. Nulliparous, infertility. Tenderness in POD because there is pouch of Douglas, endometriosis. Uterus is retroverted in endometriosis. So this is clear-cut classical question for endometriosis. 38-year-old female diagnosed with endometriosis on laparoscopy. She is infertile. Bilateral endometriosis in ovary. Adhesions in fallopian tube and pouch of Douglas treatment. They are wanting the treatment. What treatment you are going to give? Will you do hysterectomy in this patient? Nothing is written in the question, her family is complete or not. So I am not going to do hysterectomy. Is progesterone going to treat endometriosis or Mirena going to treat endometriosis? They can treat the symptom of menorrhagia, but they do not revert endometriosis. So if there is adhesions, if there is endometriotic cysts, then laparoscopic guided fulguration of endometriosis. This is the correct answer. 30-year-old lady presents with dysmenorrhea, painful coitus, infertility, uterus retroverted, fixed. What is the next line of management? Diagnostic laparoscopy. So endometriosis is very, very important for question. At least 5 questions I have made you practice. So that is how you are going to complete the revision part. More and more questions so that you know exactly how to mark the answers. That's what, this is a practice session I have given you. Enough of practice. Beyond this is not possible for me. I've already done my best. You have to do your best now. 43-year-old female, big question which is sometimes surprising these students in the exam. Clinical question. 43-year-old, remember the age. Pain during periods, dysmenorrhea. Heavy periods, menorrhagia. And pain starts before the onset of periods, congestive dysmenorrhea. Congestive dysmenorrhea, menorrhagia. And she has 2 deliveries. There is tenderness in the abdomen and size is 10 weeks uterus tender. Tender uterus, 10-week size, dysmenorrhea, menorrhagia, 40-year-old female. What did I teach you in the class? This is classical adenomyosis. See, many times बहुत सारी राम कहानी लिखी है. But what you have to grasp is the hint in the questions, like first is the age, 43. Number 2, pain starts before the periods, congestive dysmenorrhea. Heavy periods, menorrhagia. Enlarged uterus, tender uterus, 10-week size uterus, and image. Anyhow, I don't find any single student who can mark it wrong with so many hints in the question. Already you have attended the class, already this has been discussed in the class, and there's a clinical question created. Okay, so as to mark, and that to tell you that there is so much of myometrium increased in size and endometrial lining is been thinned out. Can you see? This is myometrial hyperplasia because there is presence of endometrial glands in the myometrium. That is adenomyosis. You can see laparoscopic image of adenomyosis. Okay, can you appreciate this bluish colored gland in the muscle, myometrium? So this is adenomyosis. Now, all of the following treatment are applicable in this case except what will not work? GnRH analogues will work, hysterectomy will work, tranexamic acid, mefenamic acid will work, LNG IUD will work, uterine artery embolization has got no role. We are just discussing because aim is to revise the content. So take it this way. This way is the one which is correct way I am discussing. Fine. You have to take home the important concepts. That is what you are taking. That's fine. Is that marks important of the revision session, or it is important that you make the answers correct in your exam? चलो समझ आ गया सबको, आ जाओ. A lactating female comes to you with complaints of dribbling of urine and difficult prolonged labor 4 months ago. What is the most likely diagnosis? What's your answer? This is vesicovaginal fistula, VVF. That is true incontinence of urine from vagina. And there is a history of prolonged and difficult labor. So what happens? That the presenting part tries to apply pressure to deliver, but that lands up in obstructed labor. So there is ischemic necrosis of bladder. After 1 week or 10 days, she comes with continuous dribbling of urine. क्यों? क्योंकि जो pressure लगा bladder पे by the presenting part which was not delivered, so उसने ischemic necrosis कर दिया urinary bladder. That is sloughing of bladder mucosa. So continuous opening बन गई between urinary bladder and vagina. So that is she's continuously dribbling urine from vagina. There's a history. Prolonged labor, difficult labor, now constant dribbling of urine. So it is VVF. Vesicovaginal fistula. Identify the instrument used in gynae. Babcock's forceps. This is used for tubal ligation. Babcock's forceps used for tubal ligation. 28-year-old female has foul smelling discharge. Saline microscopy was done. What do you find in this image? Clue cells. What is this? Bacterial vaginosis. Clue cells, bacterial vaginosis. Lady comes with thin, frothy discharge, red vagina. Saline microscopy, motility is seen. Motile organism. Red vagina is strawberry spots in vagina. Strawberry spots. Frothy green discharge is trichomoniasis. Trichomoniasis. Thin, profuse, creamy, greenish tinge discharge, trichomoniasis. Strawberry spots in vagina, trichomoniasis. Okay. Amsel's criteria, bacterial vaginosis, cottage cheesy discharge, candidiasis. I hope this is clear to all of you. False positive bar body is 47XXY. This is Klinefelter syndrome. Absent bar body, Turner syndrome. And all males, absent bar body. There is no sex chromatin because 46XY. 48-year-old lady underwent hysterectomy. 7th day, fever, burning micturition, continuous dribbling of urine, and she can pass urine voluntarily. This is uretrovaginal fistula. See, from one kidney there has been fistula, so dribbling of urine. Another kidney normally draining the bladder, so there is involuntary passage of urine plus voluntary passage. इस किडनी से यूरिन यहाँ पे आ रहा है तो वॉलेंट्री व्हेन शी वांट्स शी कैन पास यूरिन एंड इनवॉलेंट्री पैसेज. सो दिस इज यूरेट्रोवेजाइनल फिस्टुला. मतलब hysterectomy has been done and there is some ureter injury, so there is continuous dribbling of urine plus whenever she feels like she can pass urine, so involuntary and voluntary passage, it is uretrovaginal fistula. See, suppose left side ureter injury was there, so there is continuous dribbling of urine. This kidney is normal, ureter normal, so urine collecting in the bladder. So this is involuntary passage, continuous and voluntary passage. So voluntary and involuntary ureteric fistula, continuous dribbling of urine from vagina, ureter fistula hoga. 60-year-old female, para 4 L4, 3rd degree cervical descent, cystocele, rectocele plus, there is a decubitus ulcer. This is what is a decubitus ulcer. That the cervix is lying outside, so there is development of this ulcer because of congestion, venous congestion. When cervix is lying outside, venous return gets obstructed. So there is formation of a decubitus ulcer. So what is the treatment for decubitus ulcer? Reposition of cervix in vagina and doing a glycerin acriflavin packing. Reposition of cervix in vagina and doing glycerin acriflavin packing. So that is how the decubitus ulcer can heal. Reposition of cervix back into vagina and doing a glycerin acriflavin packing. So what is the treatment? Ulcer healing with glycerin acriflavin packing. Hysterectomy will not solve the purpose, because how do you do vaginal hysterectomy? Like this is the cervix, you have to make a flap like this. So जहाँ पे भी आप incision दोगे वहाँ पे bleeding start हो जाएगा. So you have to let the ulcer heal first, then you can do hysterectomy. So first step is healing the ulcer by acriflavin packing. Most common type of genital prolapse is cystocele. Cystocele means bladder prolapsing in the vagina. Amsel's criteria is used for bacterial vaginosis. Patient underwent radiotherapy for cancer cervix. Which organ is most sensitive? Ovary. 19-year-old girl presented with generalized weakness, weight loss, amenorrhea, low-grade fever. All investigations are done except ultrasound, chest x-ray, TSH, prolactin, FSH. DNC is not done in unmarried girl. Anyhow, it is not going to solve any purpose. This method is used for LEAP. This is LEAP instrument. Identify the instrument. This is uterine sound because uterine sound has got markings. This is bladder sound. It has no markings. All of the following reduce the size of fibroid except OCPs. OCPs do not reduce the size of fibroid. So the gynae part is been done and I have covered up all the topics: disorders of menstruation, contraception, infertility, ectopic pregnancy, trophoblastic tumors, PID, vaginal discharge. Question number 81. It is intermenstrual bleeding, 48-year-old female, no associated pain, no hot flashes. POP is been given for contraception, uterus is normal, non-tender, adenexa free. And there is investigation given. Next line of management. This type intermenstrual bleeding and this kind of ultrasound, this is hysteroscopy because it is endometrial polyp. This is feeder vessel sign. It's not written in the question, but this is endometrial polyp because the typical history intermenstrual bleeding is one of the presentation of endometrial polyp. And endometrial polyp, the investigation of choice for treatment and confirmation of diagnosis is hysteroscopy. Next, this test is done to investigate infertility. The next question, HSG showing myoma, it is normal patency, it is irregular beaded appearance. So this image of HSG shows beaded appearance of fallopian tube, which is genital tuberculosis. So the gynae part already been done and we will take up the obstetrics now.